Hello, everyone. My name is Stacy Chazen, and I am Director of Education and Leadership Programs for the American Institute of Dental Public Health. And it's my pleasure to welcome all of you to this month's AIDPH Echo Session, Innovations in Migrant Oral Health. So we're going to get started, and I'll ask my colleagues to please share their screen with today's slides, as people are still flying in here through cyberspace. So here we go. We want to start by thanking today's ECHO partners, our partners for this whole ECHO series, in fact, CareQuest Institute for Oral Health, UNLV, the National Rural Health Association, and the Oral Health Progress and Equity Network. We thank you all for your support and your partnership. Next slide. So our agenda for today, we're going to go through some housekeeping items and give you an overview of today's call. We're then going to hear our didactic presentation from Dr. Sean Boynes, who's going to be speaking about creating inclusivity for farm workers, immigrants, and refugees. We'll have time for some Q&A after that. And then we're going to go into the think tank presentation portion of today's call, and we'll focus on addressing barriers to migrant oral health, doing some brainstorming and tapping into the collective think tank of this group. And then we'll wrap up with some closing housekeeping items. So today's call is being recorded. We ask everyone to please type your email and name of your organization in the chat for our own recording so that we can see that you're here. All slides and resources referenced today will be available following today's call on the AIDPH website. We ask you to please try to avoid using any personally identifiable health information during this session. And if you have any questions about Zoom during this call, please chat with my colleague, Elizabeth Flannery, in the chat box. So for those of you not familiar with AIDPH, the organization's vision is an equity-oriented oral health workforce that is prepared to lead. And we do this by pursuing our mission of fostering professional excellence and advancing innovation in the education and practice of dental public health. I invite you to visit our website to learn about our diverse set of programs, which include an annual colloquium, which will be making its reappearance next spring, we're happy to say. We engage in a range of national advocacy activities. We offer a Dental Public Health Leadership Academy, which is just wrapping up its first year, and we'll be announcing a second cohort in the coming weeks. This Rural Oral Health Echo. We do research on a range of topics pertinent to dental public health. We offer an annual summer research fellowship, a federal service immersion program in the fall, and engage in ongoing education and awareness programs, all in support of the organization's mission. So for those of you not familiar with the ECHO model, it's based in a framework of telementoring as a way to build workforce capacity in states and communities around the country. We engage in didactic and case-based learning using a hub and spoke model through which we hope you take the learnings from this series back to your organizations and communities to affect meaningful, sustainable change. And it's an all teach, all learn model, which means we hope that you will come not only with your questions, but with a mindset of sharing your experiences and expertise with others on the call. And that's a visual depiction of it. So this year's focus is innovations in rural oral health, which recognizes the distinct needs and opportunities for improving oral health care access and outcomes in rural populations. This year's program builds on last year's, through which folks had the opportunity to earn a certificate in special topics in rural oral health. This year, you're able to earn a second certificate. You don't have to have done the first one, but you can do both. Everyone has the opportunity to earn CEUs for each session that they attend live, and then also to complete competency quizzes in pursuit of a certificate in innovations in rural oral health, this year's focus. And you can do that either by watching the sessions live or watching the recordings, either way, completing a competency exam. And I want to flag that we have reduced the total number of sessions this year to 7. And you need to complete competency exams in 6 of the 7 sessions in order to earn the certificate. please reach out to us at programs@aidph.org if you have any questions about that. And on this slide, as well as on our website, you can see what our topics are for the remainder of the year. Highlighting our session norms, a few that I want to highlight here are: we ask that everyone use first names to facilitate equality and discussion. Please add your pronouns to your Zoom name if you haven't done so already. When you speak, please share your name, your organization, and where you're located. We ask everyone to keep their video on the entire time, but to stay on mute until they're ready to talk. Limit any distractions, and please respect one another as well as personal health information. So the learning objectives for today's session are to describe current oral health disparities for farm workers, immigrants, and refugees, discuss new models of care and emerging best practices that provide quality and efficient oral health care, and discuss the challenges and facilitators to implement programs. And here we share disclosures. So with that, it's my pleasure to introduce Dr. Sean Boynes. Sean is a trained dentist anesthesiologist who serves as Vice President of Growth and Innovation at Avisis. In his position, he oversees national growth platforms and government business development and drives purposeful change by introducing new technologies and methodologies to transform oral health. We're honored to have Sean with us today, and I'm going to turn the microphone over to him.
Thank you so much, Stacy, and thanks everyone for hanging out with us here for the next little bit. Always a privilege to get to work with AIDPH, with the organization and the group here, and of course, Stacy and Annalise's leadership. They're a cool group of people, so I always like to hang out when I can. So I have also the privilege of getting to talk about migrant care. My presentation will focus a little bit more on the farm worker population. One of the main reasons is we do have some research. Obviously, there's not great research across the board for the population, but on the farm worker side, we have a little bit more insights that we can glean from that can help us position ourselves better to provide care within these areas, environments, and populations. Next slide. So just a little bit of background. We don't have exact numbers. Obviously, it's not the easiest thing for us to be able to get, but we have some acceptable numbers, and we estimate there's around 4.2 million seasonal and migrant farm workers and their dependents in the US. One thing to keep in mind is we always think about the farm workers that kind of go out. There are seasonal workers that are also part of this. And you may see an entire family that one family goes to go and pick during the day, while the other members of the family may go and work on the hospitality side. They kind of can join some of these areas and are seasonal just as much as some of the farm workers see as well. And so there's kind of, when you're talking about what migrant means, it's that you're moving from one place to the next, usually because of work. It's based out of the term immigrant and really signifies that there is a process to the way you live, that you tend to be in one area for a certain amount of time in another so that you can take care of yourself and your family. Oral health has been ranked as one of the major health problems facing this population. And there's lots of research that demonstrates that their oral health is not great and their access to care is not what it needs to be. We're lacking in research for those innovations and solutions that we want to move forward. We tend to have a lot more research telling us what the problems are, not as much research trying to define the solutions. Next slide. So many adult migrant workers do not seek oral health care. There's two separate studies that found over half of migrant workers did not seek the care regularly. Reasons are lack of time, money, transportation, and education concerning dental care. There is this overarching piece that I'm hopeful we're all familiar with at this point, that there is obviously a fear of authority within this population. Even for individuals that may be here legally, if they have recently been able to get their citizenship, there is still concern that somebody can come and take it away. And so there really has to be a high level of trust. So when we talk about some of the innovations and methodologies later, you'll see that every piece of that is foundationally rooted in a trust system. And that in order to really be able to provide care, you have to have the highest level of trust. That kind of goes without saying, because that's everyone. I think when you look at caring for this population, you have to understand that there is a fear that they'll be removed from the place they want to be the most. And so that's a pretty hard thing to get your genetics to overcome and alleviate that fear. And it takes time to build that trust. Several studies cited poor oral hygiene as reason for oral health problems. Most respondents brushed their teeth. We did have 2 studies that showed only 10 to 11% of respondents flossed. One study noted that some migrant children reported not owning a toothbrush. There's also studies that came out of South Carolina about 5 to 6 years ago that demonstrated that this population has the highest rate of sharing a toothbrush, which I would argue and opine is probably worse than not having a toothbrush, but I'm sure there are other folks who would feel the other way. But at the end of the day, we're not getting enough preventive mechanical infrastructure into these areas. Next slide. Couple of analyses that we have from states that have high populations. Studies conducted in Northwest Michigan showed that migrant farm worker children more likely have decayed tooth surfaces versus US school children, 65.2 to 16.8, so very significant. And we're less likely to have filled surfaces, 29.1 to 76. Similarly, a study in Colorado found the average decayed missing filled surfaces scores for migrant children, about 3.56, while the national average is 2.5. These studies were further supported by a study conducted at the Yakima Valley Farm Workers Clinic. Shout out to Mark Coday, who led a lot of those efforts for a very long time there. Basically found that migrant children have tooth decay rates twice that of the general population. Southern Illinois, I really did cherry pick here. I could have gone on and on. Like I said, we have lots of research that are telling us what the problems are that go back as far as the early 1980s. But it's that same research that we continue to move forward without coming up with really good solutions and studying those. Next slide. So what should we engage with and how should we look at that? This was a really interesting study. There's several that have come out. This one sort of is one of the more well cited, but they all sort of say the same, that when you really look at prioritized topics for farm workers and how researchers should look at the development of what they're doing, how they should base their hypotheses, how they should think about impacting policy, it really sets within the parameters of what you see. There's a high need for specialty care services for farm workers. They tend to have a larger disease burden and be more progressed in disease. And so in order to first tackle the disease burden before prevention, tends to be a lot of need for that beyond a general dentist. There are obviously language barriers. These are getting better with new phone apps. The good news, and we'll talk about this later, is a lot of these farm workers now have phones where maybe a decade ago you would see maybe a third. There are transportation needs and cultural barriers and a need for more outreach. On the health topic piece, the things that are at the top of their head, I wish it were oral health, but it's just not right now. It's what's chronic disease management. Oral health is part of that. They're more concerned about having healthy hearts, having a healthy body that doesn't deteriorate and move into some sort of disability, but oral health being part of it, but I'm not sure that it's recognized completely there. And then measurements of pesticides and the effect of nicotine and some of the chemicals that are used. Next slide. One of the big pieces that we've seen move forward is communication. It's really hard to get a population like this connected universally. They tend to be in different areas, sometimes hard to reach areas. Sometimes they have phone numbers, sometimes they do not. And so what the United Farm Workers Foundation was able to do with really a local partnership was develop a communication structure. And I really highly encourage you to read the Stanford Magazine article. It says people are waiting for a message, and it's true. I was very fortunate to be out in California and get to meet with the UFW Foundation, talk a lot about what they're moving forward with their web technologies. And to me, it's really a great infrastructure build that the UFW Foundation can start to be a partner to healthcare structures, can be a partner to public health to be able to more effectively communicate. They were able to advance this communication structure, which can reach out to farm workers on a multitude of opportunities. A lot of you folks know I am an Office fan. I think there's a couple Office fan people out there. You may have to Google this, but it's really the best analogy as somebody who saw this firsthand. If you remember, Ryan invented something called woof, which is a message that will go out to all your social media, your email, whatever it may be. That's pretty much, and I'm oversimplifying because there's blockchain management that allows for privacy and protection. Farm workers feel that they can securely upload their sensitive documents to have the foundation help. They have these things protected. They have legal parameters around it. But at the end of the day, it is a great mechanism because they're able to get to so much information, and people turn over where they receive their communications. This structure allows them to connect in a multitude of ways. It also allows them to accurately scan for what individuals may need. We know their most recent analysis that used this technique to survey found that only a third of individuals that they polled went to the dentist in the last year. Only 20% had their vision checked, and most of that was with mobile or portable care. The great thing about this is getting people together and getting them more knowledge. And so it's really the first time that we have this mechanism to connect with this population. And while I'm talking about California, the UFW is obviously in a multitude of states, and they have strongholds in about 20 states. And you can go to the foundation website to find out what states they're operating in and how they're starting to partner on the healthcare side for their members. Next slide. There's a challenge in care delivery of the population. I have this article, which community health workers' role in addressing farm worker health disparities. I have found it almost impossible to be successful with this without a community health worker or somebody filling a community health worker type role. They are the ones that tend to be the most trusted in the community. Most of the time that I've been able to work with this population, the community health workers I've worked with are former pickers or former farm workers. They understand the environment and where things are at. You have different trust levels with the population. Community health workers can help you figure that out. Some populations will allow you to come on and provide mobile or portable care at a grower site, but not all farm workers get along with their growers, and sometimes there's tension and mistrust. And so really mechanizing a care delivery structure has to be portable, has to be mobile. But I think where we're continuing to struggle is how do you house and how do you form some sort of base or home with which they can continue to engage. One of the coolest things I've seen, and I'll end it here, that I've seen is a federally qualified health center out in Napa Valley in California. They actually bring community health workers that are former pickers along. And so whenever they go and provide dental care, for example, and they pull someone off the line and they're no longer picking, they lose money, right? If I'm not, I get paid by the pound. So I have to go and pick everything and put it in. So I'm not paid by the hour, I'm paid by what I do. If I stop and go get dental care during my work hours, I lose money. And so what they started doing is getting experienced pickers that are community health workers that fill in for that individual and pick for them so that they lose no income and they're not worried about having to provide for their family. Next slide. I think that's it. Just have this this piece up. The World Health Organization, refugees and migrants' health should never be considered separate. We continue to do that. I'm putting it up here because it is, we're carving out carve-outs of carve-outs with the population. We didn't talk a lot about refugees, but they do tend to go into the farm worker population if that's their experience. No different than when Irish and Scottish individuals came over right around the First World War to go into the coal mining business. So I've kind of been here and done that before, very similarly, actually. Refugees, also an important group. Just pointing out, when we talk refugees, there are a lot of churches that tend to participate with refugees. And so trying to build good community development with churches and with organizations that these individuals trust become really, really important in order to facilitate predictable care. That's it.
Thank you, Sean. So we invite questions from folks. We have a pretty big group today. So we'll ask either, feel free to put your question in the chat or to say, I'd like to ask a question and take yourself off of mute, or you could raise your electronic hand by using the reactions button at the bottom of your screen. And while we're waiting for questions to come in, I will start with one. Sean, I was curious, looking at, you were talking about the app allowing for people to upload their, I think it was their immigration papers and other sensitive documents. Is the offering only limited to people who can show that they're in the country legally?
No, the whole point is to help people through the system. And so the
Okay.
United Farm Workers Foundation is connected. So the United Farm Workers Foundation was actually established by Cesar Chavez. And so it's established to help provide an avenue to citizenship, to provide structures in place that can help farm workers develop and feel at home where they're working. It also provides a lot of opportunity to participate in their communities and kind of build them up. But at the end of the day, they've built this really nice protective structure that's backed by good legislative support that allows for a good system. It's not in every state, but it's in a lot of them.
Yeah, great. I know that that's a sensitive question to ask sometime, but
It
sometimes
is. It's just, I think the UFW Foundation was able to do it because of the trust that the people place in them and the fact that they have a lot of political capital and are able to maneuver.
Yeah. Questions from the group, from our faculty? Oh, I see we have a question in the chat. What are some ideas or strategies you use to gain the high level trust you mentioned about when you come across a migrant farm worker family?
So there's a lot. I think time is probably you have to think of it as kind of getting into marriage. There's a courting process and a feeling out process. I think that's sort of the first piece. 2 is having somebody vouch for you. It's kind of word of mouth. Having somebody vouch for you and say, okay, this person's okay. I think having a good online presence that shows support, because I found that, at least in my situation, they will Google you and try to find information. I think the other piece is having knowledge about what they do and how they move, understanding the lingo. It's like anything, right? If you go into a club or a new venue with new people, you try to understand what the language is and trying to kind of think through what words are being used and why. And so I think there's a lot of trust that gets developed out of the language and the effort. So I think that's it. There's no easy piece. Even those ingrained institutions take some time for people to fill out. Fairly qualified health centers are very well known within the population as well and tend to have a very good reputation within healthcare structures. Hospitals, on the other hand, are very untrusted. And so if you are affiliated directly with the hospital, those are some things you would have to overcome. So I think the other piece is kind of figuring out what people distrust within the healthcare system. And we do have those studies.
Ron, if that's okay, I have a question too. I'm really curious about the model you described where they have someone come in and essentially replace the worker so that they can access dental care. And I think that's a really innovative way of supporting populations kind of across the board who struggle with having to balance economic considerations with accessing dental care. Do you have any information on how that program, I guess, was economically viable? Is there an ROI of paying people to come in? Is there a savings on the back end associated with those perhaps high risk individuals getting better access to care?
So a great question. I'm going to give you a slightly disappointing answer. A lot of that is driven by the money that's already in place. So if you look at a place like California, individuals that are farm workers, most of them, and I think the last numbers are almost 60%, are on Medicaid. And so there's a desire to drive utilization there. And so there are other states that have legislative actions that are very farm worker friendly, either because the growers have influence and they need people in their fields, or the farm workers union has kind of solicited and elicited that sort of response. And so where this works the most and why it's being driven is usually through managed care organizations where they have to drive utilization and care. And so it's kind of a different model. I think where fee for service is at, it's probably a little bit slower. Tends to be more integrated. Federally qualified health centers who have to prove their HEDIS and CMS scores tend to do it more. Tends to be done in areas as well where you have a lot of agriculture. Central Florida is a place, Northwest Michigan. So sometimes it isn't even a whole state. You might get this little area where they can make it work. Tends to be a lot of grant funding, tends to be a lot of support from payers or insurance companies or third-party administrators. So I think this is a place where metrics are actually working, truthfully, in some states, in my opinion.
And I know we have one question in the chat, but I'll ask just as a follow-up, is your estimation that that design probably works best in a value-based environment?
Well, it seems like a dangerous loaded question these days, but yes. Yes, it does. I mean, I think, well, it's hard to say because I mean, at the end of the day, we have very little true value-based risk shared structures, right? Everything's upside pay for performance. So yeah, if you're going to technically pay a little bit more, give a little bit more wrap on the federally qualified health center side, pay a little bit money beyond fee for service, that's how it's going to drive it. So if you package your preventive pieces together or bundle them, you can produce another revenue source for the provider that would result in shared savings and could be profit sharing between the insurance company and the providers. We would all have to come together and agree to that, though.
Thanks, Sean. Another question in the chat. Other than Spanish, what other languages are spoken within the population?
You name it, it depends on where the state is at. Like a great example is Sacramento County, where they've seen an influx of Ukrainian refugees. And it's because there's a large number of Ukrainian churches in this one area of Sacramento. And so those particular migrant individuals tend to have anywhere from Russian and Ukrainian dialects. There's Syrian refugees that are also fairly common. I think we always think Mexico, Central America, but those tend to be half, maybe a little bit more of the overall population. Also a big Asian population group over, especially when you get down into South Carolina, Georgia, and you start talking about rice growers. So it's the same thing, right? I mean, I don't know. I've always been taught that don't underestimate someone else's smarts because they read different books than you. To grow and to pick is an art form and a great knowledge. There's a city of soil, and I think maybe we underestimate the knowledge that farm workers have, but they can, develop a career and make a good living in doing these things. It's just trying to get them through the first stages of getting established within the country. A lot of folks come here legally and this is what they want to do. And this is their skill set, similar to coal miners several decades ago. And so there's a pathway for them to do the thing that they love. A lot of them love to do this. I think we think I think we need to enable and empower them more to do what they want to do for a living. There's lots of ways you can go through this. Penn State has one of the largest agriculture programs in the world. We should be taking those farm workers as they grow up and moving them into positions where they can help us with our infrastructure, which is pretty poor right now. And we could use more farmers than we have. Sorry, I'll get off my soapbox, but that was a great question. It's near and dear to my heart. So there you go.
Great answer too. All right, another question in the chat, and this is for Sean or anyone else in the group. I am assigned to Region 3 in Texas. I work mainly in Dallas and Fort Worth. What areas or agencies is anyone using to find and help the migrant farm worker families? And how successful have those areas and agencies been?
And I'll get off of mute because that was actually my question. My name's Rogelio, but I go by Roy to make it easier on everyone. So I'm coming back into, the Medicaid side and trying to find and help these migrant farm worker families. And it just seems like this area where my ad is just kind of a bit challenging because there's not many farming and things going on. So I was just wondering maybe if anyone's already working with an agency or what do you guys do to find these families here?
So, Rogelio, I live in Texas and nothing immediately comes to mind in that area aside from just working with the state and some of the limited resources that they provide, and also recognizing that legislatively some of that may have been impacted by this most recent legislative session in Texas. So
Mhm.
I'd actually love to, if you're willing to connect with you offline and see if you're really wanting to find some resources, if I can help you source those, or if that comes up naturally in the discussion as we move through the case summary. If anybody else can marinate on that and respond, that's kind of where my head goes. And I'm happy to put my email in the chat too. So if you want to connect one-on-one, I'd love to do that.
Yeah, that'd be great for sure. Thank you so much, Annalise.
And then just one thing to add to that, and even though you may be in a metropolitan area like Los Angeles or Dallas or even Houston, what we find is why these individuals may be out picking during the day, they may actually be in a urban city setting because it's better for their family and they go out. Some might go out for a couple of weeks. So one of the things that we learned through the union, and that would be my suggestion if you're looking to see where people are at and how they're living and moving in Texas, is to find out what areas and where they're going within those city centers and trying to connect with them there as well.
Thanks. Another question in the chat. There's been a lot of data that has spoken to the impacts the public charge chilling effect has had on access to healthcare and other public benefits. Has there been a noticeable increase in migrants and refugees naming this as a fear when accessing dental care? If so, is there a sense of how community health workers have responded to those concerns in ways that are receptive to the community to overcome the concerns?
So that's definitely an experience question. So I would like to know if there's any specifics. I'll answer, and obviously if there's something behind it, would love to know. Yeah, it's an amazing fear. I think it's a fear. It's also a fear of trying to address that fear. So we kind of compound it a little bit. We really are sort of at the beginning of trying to establish a process and an infrastructure. I think it's been really difficult. I think this population has been very separated for quite some time. I think it's been easier to do that, not just from a standpoint of trying to deal with it holistically as a society, but I think from a healthcare standpoint, we've been able to sort of hide behind what is a challenging outreach effort for what is a majority of citizens that we as society want to take care of. So I guess I'm not giving you a complete answer because it was a well-constructed question that there's not a great answer. We're trying to figure those out. I'm assuming what we need to start doing is get our best practices together because we don't really have that established as well as we'd like. I think we're still pulling together these ad hoc one-offs and no coordination is happening. And I think what the UFW with this new app is allowing is sort of a centralized place for us to at least communicate, which we've never had before. So that's why I included the slide. It's really the first time we can mass communicate effectively and accurately to this population. Everything's been 40, 50 at a time. And all of our research is 40, 50 at a time. This is now looking at tens of thousands if we need to. I would love to know if you have an answer though on the back end. If there's some secret sauce you have, I would love to know. Because the question was the perfect question to just really befuddle me with no answer.
I don't have an answer, and I was just, well, thank you. This has been really helpful for me. So I'm a policy analyst, and I primarily focus on immigrants' access to healthcare. But I think one of the issues that some of my colleagues have brought up in Community Catalyst is just the need for the further integration of the medical and dental sphere of the work, right? And I know that is a very familiar issue to all of you here. And I think I've been in multiple spaces where we talk a lot about the public charge rule and we talk about the impacts that it has on healthcare, but it's generally in the context of seeing your primary care doctor, right? Like it's really looking at the medical side and not so much dental and oral health. And so I was just curious if there's any specific insights or ways to support that, because I know that there are, the barriers that you named are just barriers that folks face to even have initial contact with the dental system and, dental providers. And I can just see like the public charge rule really compounding, or like the chilling effect of the public charge rule really compounding those barriers. So I was just curious if folks had any insights. And I'm also happy to share resources that I have from partners on public charge if that is helpful, because I think there is no need to reinvent the wheel if there are ways to adjust those messages to be more applicable to you all. I think that's always something that should be considered.
Thank you, Catherine. We appreciate that. And if you want to share those resources with us here, to email those to us at programs@aidph.org. We'll include those in the follow-up materials from today's session. So thank you for that offer. And thank you, Sean, for the excellent presentation and sharing your insights, and to folks for posing some thought-provoking questions. We appreciate all of you. We're now going to turn to the case presentation portion of today's call, and we are thrilled to have with us Dr. Mary Tabrizi, who is an associate professor at the University of Nevada in Las Vegas at the School of Dental Medicine. As background, actually, I'm going to have Dr. Tabrizi present this. I'm going to turn it over to her now, and she can talk about her work, her background, and the questions that she has for all of you today.
Can you all hear me?
Yes.
Thank you very much for the invitation. I do not take this lightly on such a topic, such an important topic that you are focusing on. My background, I'm a geriatric dentist. However, I have worked in the past with a lot of, as part of my public health dentistry, with a lot of migrants and refugees. And the question, I'm going to go through this quick. I know my time is very short because we were getting a lot of important information. I'm just going to stick to a few things. I think it relates directly to actually Catherine's question, that how dentistry and oral health is involved with this. That's an excellent question. And I hope I'll be able, through my short presentation, I'll be give you a couple major points that I'm sure the policies can help to, if not minimize, at least decrease some of these problems. Working with refugees and working with migrants, one of the major issues, as I have worked with them in different states, in communities, churches here and there, one of the major issues is their cultural understanding of oral health. And as Dr. Boynes, I hope I pronounced his name properly, as he just said, it's very important to be able to recognize if somebody's intelligent or smart, not based on the book they've read. What they know is their reality, and every culture has their own reality, and bringing them under all the umbrella of the way we see oral health is not very productive. One of the few things that I found very important is just simple oral health. They don't believe that going to dentist is it's a must unless they have a toothache. You only go to dentist when you have a toothache. You only floss your teeth when you have food stuck between your teeth. The other thing is children's deciduous teeth are going to fall out anyway, so there is no need to having any care for them. And sometimes based on their religions and cultures, it is very important for wives and daughters only go to female dentists. The language is a huge barrier. So when you compound all these elements that may not seem so interesting, so I must say, not interesting, so impactful, but as a cluster, they become a huge barrier. They just don't go. It's a lot easier to avoid than dealing with all these factors. And as a result, the only solution I found over few times that I volunteers with those things, having a social worker on your team, having a public health advocate on your team, especially somebody who knows that specific culture, or even better, they speak that language, the whole trust changes, the whole bond changes. As a result, the clinical outcomes improves. And the best way to actually for most dentist is to be able to have that cultural competency that in a way can actually come into the part of a 4Ms in a form of what matters most, which is the umbrella over the whole thing, to recognize in their own way, not in our way, in their own way, to be able to recognize that if every individual needs and be able to provide a person-focused, not a patient-focused, a person-focused plan that includes each individual's understanding of what we think is good for them. However, be able to deliver this in a language or in a culture, in an understanding that they can agree with us. Otherwise, and those things do require policies. Those things do require guidelines, and I think that's one of the major things that we are missing, especially in the area of oral health, because unfortunately, it's not yet as a part of coding code healthcare. A lot of us are working very hard on it. We have come a long way, but we still have a long way to go. For example, in a whole foundation of the 4Ns, in a team of those who actually came together and created this wonderful guidelines for health, for age-friendly health system, or migrants or refugees, people with special needs. We had, there were every representative from most of the healthcare disciplines, but not a dentist or a dental hygienist. So it's been kind of in a back burner. However, it's not going to stay there for long, because we are seeing more and more the importance of it, the connection of it, and how much we have to work as a teamwork within a culture, within an understanding of what they have. So that's kind of in a nutshell that what I have to say. I rather leave more time for specific questions, because I can talk a lot more details according to the questions. And again, thank you for having me on this session.
Great. Thank you, Dr. Tabrizi. So as folks know, what we're going to do now is we're going to go into breakout rooms so that we can brainstorm some answers to Dr. Tabrizi's question, which is, what are the best ways to equip providers with a better understanding of the social determinants of migrants' health and oral health? So folks are going to see an invitation to a breakout room. About 1/3 of you are going to stay in the main room. That'll be your breakout room, so to speak. And we're going to be in the breakout rooms for about 10 minutes, and then we'll come back together. Hey, everyone. So we're going to wait till everyone lands here. And we're recording this session as well so that we can capture notes to be able to prepare a case summary after today's call. Okay, so I'm going to ask if folks could put their cameras on. That would be wonderful. And then we can engage a little bit. Hi, Christina. Good to see you.
Hi, Stacy. Sorry, my schedule changed, so I'm at home. So you see background.
It's all good. You see my background too?
Yeah, yours is pretty. It's nice and green. Makes me think of the East Coast somewhere, like, you know, one of
That's what it
those
is. That's where I
beautiful.
am.
Is that where you are? I thought you. Oh, okay. There you go.
Yeah.
That's right, Stacy. Okay, we're good.
I'm at the Jersey Shore.
Ah,
So welcome everyone. So the question that we're considering, Dolores, good to see you. Thanks for putting your camera on. Is what are some ways that that they can make providers aware of the social determinants of health and oral health of migrant and rural populations?
can I chime in first,
Please.
Stacy? And we'll get everybody on board. So I think it's very important for individuals to even understand some of the barriers that Dr. Boyens and Dr. Tabrizi talked about, but more specifically, those social determinants of health. And on a previous ECHO session, we talked about the social drivers of health. So it's just making them aware of what it can look like. I think sometimes immersing people in that population. So maybe if you're talking about pre-doc dental education, actually having them go on a rotation in a migrant farm worker facility, going to an FQHC, maybe with a higher population of refugees. Same thing across all health professions. So I think it's just increasing the awareness and the education amongst health professionals in general.
Great.
That's exactly what I was going to say. So I'm a clinician myself. I'm a dental hygienist. And just saying that to say, I learned a lot today and I'm a dental hygienist. So raising awareness through things like an ECHO or a webinar from someone who has great experience working with this population. But I would also add on to say, you know, if it would be possible to actually hear from those people in the community themselves. So not calling them patients. I'm trying to stop myself. And you know, raising awareness through storytelling directly from the people themselves that are within that community.
And I think that's why Dr. Boyens brought up the community health worker or primatoras or individuals from the community. They would feel much more comfortable. So we're here in Las Vegas, and our Clark County School District received money from the city because they noticed a huge influx of refugees, and the young kids that were going to school were not comfortable speaking English, let's just say. So they developed this family support center to not only educate the young kids to be able to get into the school setting, testing well, but they also provide guidance for the parents to learn the language, learn the computer to get them enrolled in school. So we actually did oral health services a couple of weeks ago, and there was such a high, not just Hispanic population, which we were prepared for because we see a lot of Hispanic patients at our school, but a lot of other refugees. So even in Las Vegas, we have such a robust workforce, I guess you would say, but we all are not as comfortable with the other languages. So what we found was there were still some barriers. We were very, very comfortable with obviously English speaking and Hispanic speaking, but like they were saying with some of those other cultures that have recently come into Las Vegas, we ourselves are not as equipped. I mean, we did the best we could, but having translators and interpreters from a community health worker or somebody from the community that speaks that language very fluently, I think is very beneficial.
And Fallon put in the chat at the WIC clinics I go to, using the live over the iPad, live interpreter over an iPad is such a huge help. Yeah. And I'm curious, to what extent at the UNLV Dental School do you cover this in the curriculum?
It's all part of our coursework, so it falls on me, Stacy. So we actually, yeah. So we do integrate it within not only our public health courses, we do integrate it within our cultural competency and communication course, and we do implement it within just our clinical care. So basically across the board, it's integrated within our curriculum. It's integrated within our outreach services. So when we do our evaluations for our students that are on a rotation, one of the questions we ask is, how do the social determinants of health impact the community, right? We also do have a poverty simulation. And again, after the poverty simulation, our first year students have to reflect on it. And we bring in the social determinants of health. When we do case-based assessments in our courses didactically, or even, you know, based on other work that we do, it's part of it. So we've integrated it across the clinic, across the coursework, just because in Las Vegas, like many other states and cities, we have a very, very diverse patient population, we have to be as cognizant as possible to their needs. So yeah, we have integrated it within curriculum, our community service, as well as clinic.
That's pretty cool that you include that in your curriculum, because I'm thinking back to my dental hygiene school. I think the only thing we learned was the cultural competencies, and that was kind of required for us to learn. But my background in public health, I feel like I had to navigate as a workforce provider. Like I had to navigate between the clinical aspect of it and the public health aspect of it, because we tend to focus on clinical, but once you go and deal with migrants and refugees, which is mainly my experience, was like completely different. And having, like you said, the gatekeepers of those communities involved and having an established relationship with them helped a lot in making those connections and making the population even more comfortable with us.
And Christina, could I just ask quickly, do you guys have anything like publicly available, explaining in any facet how you implement this in your curriculum, whether it's some sort of something on your website about the curriculum, or maybe like a scientific publication? Do you have anything? This is just great reference, and I would love to make sure it gets shared if you do.
We have it within our syllabi. So within our syllabi, we have to write down what references or resources we use. It's not publicly available, but it is owned by me as a course director, so to speak. I mean, it is our information. So I can definitely share that with you, and you can do it. So the resources are on there. So when I do the instruction, I go through every step of social determinants of health and how it would apply with a specific case scenario. And as I think it was Aman was presenting, a lot of students go to dental school for the clinical aspect. And I always say you have to take the clinical hat off and put on the more public health service oriented hats. So I tie in a lot of our didactic work with clinical care because they do want to be dental providers, but my background obviously is in public health. I want them to focus on that. So I'll show you what I have, but all of my lessons, every time I do it, is didactically founded on the evidence, but how is it applicable or how can it be applied in a clinical setting or in a community-based setting? That way I can cover both bases, because I know the majority of students want to just go practice and be good in a private setting or corporate setting, not necessarily in a public health setting. But I'll share with you what I have.
Absolutely, thank you.
Other thoughts about what providers need to know and how that information can best get to them? I will say that I was really fascinated when Sean was talking about the community health workers stepping in to help with the picking, so that the workers are not losing income when they go to their appointments, and just thinking about how that could be adapted in so many different. I would think a lot more easily, that it would be a lot easier to find someone to step in for you if you have an administrative job or that's such a specialized physical labor job. What the potential is. I'm curious if anyone has heard of any programs like that where, no, I'm seeing heads. Yeah, that's really fascinating.
I thought it was very innovative. I know we're in academia, obviously, and sometimes when a person needs to take leave, people can donate leave so that they can take more leave. Right. Which is not, it's not the same, but I'm like, the idea is there. It's like, how can we help the person that's most in need, right? So in this case, it was just giving them leave. But I really like what he said, because rather than them losing the amount of time it would take to do their work and maybe have less resources or money available for their family, somebody else jumps in. So it was very innovative, but I haven't heard about it in the sense of healthcare. No.
Well, welcome back. I hope everyone's breakout rooms or main session room were as engaging as ours was. I thank you all for your contributions. And as those of you who've been a part of these calls know, we'll be producing a summary sheet of the recommendations that came out of each room. We'll be sharing that with you, Dr. Tabrizi, and also posting it on our website with the recording. And if you could take us back to the slides, Annalise, we will close out. So next steps, as I shared earlier, CEUs are available for today's session. The survey link will show up in your browser right after this call. Recordings and the recording, the resources, and the strategic recommendations will all be shared on our website. If you would like to present a case to our think tank on a future call, there's also a link to that application on our website. We invite cases related to rural oral health. Our next call is going to take place on August 17th at 2 p.m. Central Time on the topic of partner and stakeholder engagement. So be on the lookout for the registration link for that. Liz, is that already available? That registration link? Great. So before you forget, go ahead and register. And Liz has posted that in the chat as well. So we thank everyone for joining us today. Thank you to Dr. Boynes, to Dr. Tabrizi. It was a pleasure to have both of you. And we look forward to seeing you all again in 2 months on our next call. Thank you, everyone. Bye-bye.
Been a pleasure. Bye-bye.
Thank you. Bye-bye.